Good evening, everyone. It's Ted Harrison, the admin officer with the HCP group. I'd like to welcome you back from our summer off. This is our first case round of the fall. I'm going to keep the introduction very brief. Nick's got a really good presentation lined up for us tonight. If you didn't see in the email, though, we do also have a field trip that's going to tie in with this. There's a couple of spots left. So if you are interested in coming to see the Hyperbaric unit at Vancouver General Hospital, give us an email at the SJ Facilitator Gmail account, and we can get you signed up. So there's about 2 or 3 spots left for that. Next presentation for next month should be announced shortly. We've got a few things lined up for the fall, so stay tuned for that. And without further ado, I'll turn it over to Nick, and Nick will introduce himself. All right, here we go.
Hi there, folks. My name's Nick Hume. You guys normally know me as the training officer for the HCP group. I also have another life as well, or several other lives. Tonight we're going to be talking about diving and hyperbaric emergencies. And specifically, we're going to talk about mechanisms, physiology, and management. I'll get into a little bit about that as we go along. For those of you who know me only as a paramedic with BC Ambulance or only as a training guy with St. John, I do have a fairly long and some might say sordid history in diving and hyperbaric medicine as well. I've logged somewhere in the neighborhood of 800 dives over about 20 odd years. I've been a diver on and off for like several years very intensively, and then taken a few years off and several years very intensively. Quite a bit of that has been as a technical deep diver. So I've logged dives. I've logged a couple hundred dives down to about 250, 270 feet, breathing helium. I trained as a dive medic with the Diving Diseases Research Center out of Plymouth, and I actually did my training with the Thai Navy in Bangkok. It's a very long story. You can ask me over a beer sometime. I'm also a primary care paramedic with BC Ambulance Service. I also do all the stuff with St. John. So I do have a fair bit of breadth in the stuff, or breadth of knowledge in the stuff that we're going to be talking about tonight. I am going to apologize in advance, by the way, guys. This is going to be a very dense and fairly fast-moving talk this evening. So if people feel left behind, please save your questions for the end, and we'll try and get them answered at the end of the talk, or online in Facebook comments or YouTube comments afterwards. So tonight we're going to be talking about a few things. We're going to be talking about diving physics and physiology. We're going to be talking about what dive and hyperbaric emergencies are and why they happen. We're going to talk about how we recognize them. We're going to talk about what we do about them. And I think we're not going to have time, if we get into having any free time, we can talk about some other diving oddities and the like. A lot of tonight is going to be talking about the physics and physiology of dive injuries, because the management of them is actually really, really simple. Which brings me to our first, and this is going to be one of our last slides. If you forget everything else that I yak about tonight and everything else that I say, take this slide home with you. This is really, at the end of the day, at the EMR PCP level, everything you need to know about managing diving emergencies. Until proven otherwise, patients with a suspected dive injury caused by a rapid ascent or missed decompression stop should be regarded as unstable, very, very unstable. We'll talk about why, we'll learn about why. Your management of them is going to be to give them as much oxygen as you can possibly flood their body with. You should be ready for neurological, respiratory, and pain complications. You should under no circumstances give them Entonox. It's like the most contraindicated thing you can possibly think of. Try and get as much information about what they were doing before they got injured as you can, and take them to hospital. And if you have access to EPOS or Tango One or TA or any of those other fancy resources through BC Ambulance or anywhere else, give them a call. That's the super condensed. I turned my entire hour-long lecture into one slide for you. So, even shorter than that, give them lots of oxygen, go really fast to a place with a hyperbaric chamber or a helipad. Having said that, we'd probably like to know a little bit more detail about dive injuries, so we're going to talk about physics. You didn't realize we were going to talk about physics today, did you? Sorry, guys. I hope everyone's like really up to speed on their grade 10 gas physics, because whew. There is actually a lot of physics and physiology in this talk, because I want you guys to walk away with hopefully a rudimentary understanding of what's going on with dive injuries and why they are the way they are and what causes them. Because if you can understand that, how you manage them becomes really, really obvious and really, really straightforward. Dive injuries to a lot of folks are these big scary things because we don't understand the physiology, we don't understand the gas physics. And if you can get even the basics of it down, it's pretty straightforward stuff. So we're going to start today with compressed gas physics. And specifically, we're going to start with atmospheric composition. Look, I've even included a picture of the composition of the atmosphere for you guys, just in case anyone had forgotten. You guys probably remember this stuff from like high school, but our atmosphere, the stuff that's surrounding us right now, is about 78% nitrogen, about 21% oxygen, and about 1% argon, and a bunch of other stuff. There's some carbon dioxide, there's some water vapor, there's probably some carbon monoxide. There's all kinds of like really unpleasant things, but they're in really, really small concentrations. We don't really care about them today. The two numbers you need to remember are about 21% oxygen and about 78% nitrogen. Ratio of about 4 to 1. We're going to come back to why that's important later. So how do we measure atmospheric pressure? Because again, tonight's talk is all about pressure. Atmospheric pressure in the context of what we're going to be talking about in hyperbarics is measured in what we call atmospheres. And the pressure of one atmosphere is what the air pressure, or the weight of the air column above us, weighs at sea level. So if I'm standing at sea level, I am at 1 atmosphere of pressure. That does, if you like numbers, that works out to 14.7 psi, or just over 100 kilopascals. We're going to talk about atmospheres for the most part. So can we talk about pressure underwater in terms of atmospheres? Absolutely. So subaquatic pressure, as a diver descends below the surface of the ocean, subaquatic pressure can also be referenced in terms of atmosphere. It can also be measured in psi and kilopascals and all these other things. As I mentioned, at sea level, at 0 meters of depth under the ocean, and I am going to talk mostly about ocean water today. This changes very, very slightly if we're dealing with freshwater, but not really substantially. It's like 4% or something off. Pardon me. So at sea level, you're under 1 atmosphere of pressure. That's the number farthest to the right. As you go down 10 meters, you've now doubled. So every 10 meters of seawater is about 1 atmosphere of pressure. So you go down 10 meters, you're under 1 atmosphere of pressure from the seawater, another atmosphere of pressure from the atmosphere above you, for a total of 2 atmospheres. You go down 20 meters, you're at 2 atmospheres of seawater, 1 atmosphere of gas, for a total of 3 atmospheres, and so on and so forth. 70 meters, 231 feet, you're under about 7 atmospheres, 7 times the atmospheric pressure that you would normally get from gas, just from the water itself, and then another one on top of that from the actual gas column above the surface of the water. Quite a bit of pressure. Think about that in terms of psi. So remember we talked about 14.7 psi, so multiply 14 by 8. Starts to be fairly big numbers, right? So what happens to gases when pressures increase? Has anyone ever held a balloon underneath the surface of the water, or pulled it down? If you do it far enough, if you pull a balloon down far enough, you'll notice that the deeper it goes, the more it shrinks, because the gas gets compressed as the bubble, or as the, I keep saying bubble, sorry guys, as the balloon gets deeper and deeper. So we're not going to go into the math too brutally. I had to put this here because all of my mentors would shoot me if I did a talk about this and didn't include Boyle's law. The very basics of Boyle's law are that pressure and volume are really closely linked. As pressure increases, volume decreases. As pressure decreases, volume increases. We're not going to talk about temperature, and don't worry about the equations at the bottom. They're there if you're a bit of a nerd and you want to know about them. The general gist of this is that when we as we go deeper underwater, pressure increases. The deeper we go, the more the pressure. So what happens when we compress gas in the presence of a liquid, right? So we've just talked about actually compressing gas. What happens if we have gas side by side with a liquid? As environmental pressure increases, the potential gas that can dissolve into solution also increases. It's the same as, for example, dissolving sugar in your tea, and you can dissolve more sugar in hot tea than you can in cold tea. You can dissolve more gas into solution under high pressure than you can under low pressure. The higher the pressure, the more gas can be dissolved into a liquid. Gas also precipitates out of solution, so the exact opposite of what I said. As the environmental pressure decreases, the gas that can be dissolved into a solution also decreases, or the potential gas that can be dissolved into a solution also decreases. So the lower the pressure gets, the less gas can dissolve in a liquid. When a dissolved gas precipitates or comes out of solution, it once again enters a gaseous state and becomes gas instead of this stuff that's dissolved in fluid. The really obvious example for all this, and I think everyone is probably familiar with these, are carbonated drink cans. So a can of Coke or soda or whatever you want to call it. The contents are stored under pressure to keep the carbon dioxide dissolved in the fluid of the drink. While the can or the bottle is under pressure, the gas that is going to become the fizzy bubbles stays in solution. As soon as you unscrew the cap or crack the top of the can, you decrease the ambient pressure by opening the can. All the gas gets pushed out of solution really, really fast and forms lots of bubbles. That is what we've just talked about there, is the sort of the basics of gas solubility that we're going to be needing to understand stuff going forward. So what happens when we mix compressed gas physics with human physiology? Oh, pardon me, guys. I'm going to mention, by the way, if there are any questions, I think I said this, please do keep them to the end. I am intentionally not stopping to explain terms that I think many of you will know. If I use any anatomical, physiological terms that you're not familiar with, please take a note, throw them up. We can try and clarify stuff at the end. But yeah. So, gas exchange in human physiology. Blood carries oxygen to body tissue from the lungs. We all know this. We all learned this in like standard first aid or whatever first aid course we did. And we probably learned it in high school biology. Blood also removes carbon dioxide and carries it from the tissue back to the lungs, where it's dumped out into the atmospheric gases inside our lungs, exhaled, and we get rid of carbon dioxide and acid that way. The primary means of oxygen and carbon dioxide conveyance between the lungs and the tissue is via hemoglobin, specifically oxyhemoglobin when it has oxygen bound to it, and carboxyhemoglobin when it's got carbon dioxide bound to it. That's how like 99 point something % of the oxygen and carbon dioxide that our cells use for metabolism gets moved around our body between our lungs and our tissues. What we don't often think about, especially at the BLS level, is what's called arterial blood gas. And I'm not going to go into ABG measurements and draws. If I can imagine Ted and Mandy cringing, going, why is this guy going into so much detail right now? Blood also carries gas that's dissolved in plasma, the same way that carbon dioxide can be dissolved inside your Coca-Cola, inside the can. Gas like oxygen, nitrogen, other gases can be dissolved. Helium is another good example. We'll talk about why later. Can be dissolved in the plasma of your blood and carried around your body, right? Plasma only carries a very, very small percentage of the oxygen and CO2 that's actually being passed around your body. It doesn't carry a lot, but it is important that it does carry that stuff. And specifically, the amount that it carries, we're going to get into this, increases the deeper you go underwater. So oxygen and carbon dioxide are metabolically active gases. What that means is they both bind to hemoglobin, as we talked about earlier, if any is available. And they're involved in cellular respiration and other physiologic functions. Your body uses and does things with both oxygen and carbon dioxide. Nitrogen and other atmospheric gases, including helium, and again, we'll talk a bit about why helium is important later, but I will keep mentioning it on and off throughout this talk, are metabolically inert. They don't bind to hemoglobin. They don't interact meaningfully with other cellular mechanics or physiology. It's a little bit of a lie. They interact in special circumstances and in special ways. You can have nitrogen narcosis and stuff. We're not getting into that. In the context of decompression illness and bends and diving injuries, we're going to say that they're metabolically inert. And they are carried through the bloodstream as dissolved gases in plasma. Right? So if you're still having trouble wrapping your head around this, this is a very crude illustration that I stole from the internet. I forgot to record the website that I stole it from. It was some university down in the States. But as you can see, oxygen in solution floating around in this sort of like the white space that represents the plasma. And then oxygen bound to hemoglobin, the little green balls bound to the four noduled red things. The red things are supposed to be the hemoglobin. The green things are supposed to be the oxygen molecules, right? So as we increase the pressure, we increase the amount of gas being forced into solution in plasma, right? This applies equally to oxygen, nitrogen, helium, and any other gases that happen to be in breathing mixtures. Believe it or not, people breathe xenon sometimes. It's kind of wild. That's really gnarly stuff. It might have gone out of vogue recently, actually. I'm not sure, but we can talk about that later too. So we have a look at this. This is my own fabulous artwork here. I expect plenty of compliments on my drawing skills in Photoshop. At 1 atmosphere, we have a little snapshot here of 1 molecule of hemoglobin, 4 molecules of nitrogen, 1 molecule of oxygen. You remember that 4-to-1 ratio I was talking about? At 2 atmospheres, we have 8 molecules of nitrogen in solution. We have 2 molecules of oxygen in solution, and then we have 4 more molecules of oxygen bound to the hemoglobin. At 5 atmospheres, we're up to now 20. So 132 feet, by the way, 5 atmospheres is about the limit for standard recreational diving. That's about the limit of the stuff that you're more likely to come into contact with in emergency situations. We'll talk about some of that later as well, but this is sort of the upper limit of what you guys are probably going to see. So you've still got your 1 hemoglobin. You've got your 4 oxygen bound to the hemoglobin, or 4 carbon dioxide if it's heading back to the lungs. You've got 5 extra oxygen molecules floating about in solution. You've got 20 of these nitrogen molecules bouncing about in solution, not really doing much and just sort of generally getting in the way. As with all fluids, gas also dissolves into solution in plasma, as well as all of the other fluid spaces in the human body. So not just plasma, but also the organ tissues that comprise the rest of your body, the synovial fluid in your joints, the vestibular fluid in your ears, your cerebrospinal fluid. All of these things will actually have gas absorbing into solution, or dissolving into solution, being absorbed into these tissues when under pressure. The higher the ambient pressure, the more gas is dissolved into solution in all the fluid permeated spaces of the body. I won't really get into too much about how osmotic pressure gradients works and how partial pressures go. Again, I'm trying to avoid getting too into the mathematical nitty-gritty, but basically the more gas we dissolve into plasma, so the more nitrogen and oxygen we dissolve into plasma, the more nitrogen and oxygen is available to be dissolved into cellular fluid, into cerebrospinal fluid, into vestibular fluid, all these other things. So this slide is really important. This is sort of like the other takeaway slide that I would like you guys to remember from this talk. The higher the ambient pressure, the more gas will dissolve in plasma and tissue. So the higher the pressure around the human body, or the pressure of the gas that's being breathed in, more gas will dissolve into plasma and tissue. If lots of gas dissolves into plasma and other fluid at pressure, and then the ambient pressure is gradually lowered, the gas will form really, really small microbubbles, be transported to the lungs, and can be breathed out. So it'll form little bubbles in your blood plasma, it'll form little bubbles in your organ tissue, but it'll sort of manage to make its way back to the blood. I'm being slightly technically inaccurate here, but it'll be able to be passed out and expelled by your lungs. If lots of gas dissolves into plasma at pressure and then the ambient pressure is rapidly lowered, the gas is going to form many, many bubbles that merge together and obstruct blood flow and damage tissue. Bubbles can be too large to be carried to the lungs, and they actually become emboline, do things like block arteries and cause gross tissue damage and all kinds of horrible, horrible things. The latter eventuality is generally regarded as a bad thing, is something we should really strive to avoid. In the context of diving, what this means is that if you are at depth, you have all this dissolved gas in your tissue, in your blood, in your cerebrospinal fluid, in your vestibular fluid, in your synovial fluid, all these other places, and you come up really, really slowly, you have enough time for all of that dissolved gas to get carried back to the lungs and breathed out safely. If you come up really, really fast, or faster than the recommended safe ascent speed, which is a controversial subject in its own right, the gas will form bubbles in places in your body, and those bubbles are going to cause problems. This is sort of like the general gist of hyperbarics, right? Or barotraumatics, barotraumatics. More depth, more pressure, more dissolved gas. So if you're only down at 10 feet or 3.5 meters underwater, believe it or not, it is possible to get a dive injury from like a 5-meter dive if you do it wrong enough. But you have to try fairly hard, generally speaking. It's fairly easy to give yourself a dive injury from diving down to 200 feet and then coming up quickly, right? More depth, the deeper you go, more pressure, which pushes more dissolved gas into tissue. Okay, that was a lot of new stuff. Let's take a few seconds here to look at some cute cats, because I know everyone is probably going like, oh my god, is this guy going to shut up yet? Look, it's a cat meme about paramedics. This one, I hope someone is laughing. I'm like talking to a silent computer in my apartment right now. I really hope someone is laughing at these memes. So what is a dive injury? I hope everyone had like a good little refresher break there. I'm going to open the fire hose back in your faces of me talking for an hour now. What is a dive injury? So dive injuries occur when gas expands too rapidly for the body to compensate. Bubbles cause direct trauma to tissue. They occlude blood flow and then mechanically impair organ and tissue function, right? So direct trauma to tissue means like you have a bubble that's formed somewhere that's actually like making something inside you pop or causing tissue damage. Believe it or not, microbubbles in your vasculature can actually tear the tunica intima of your vasculature as well. Some interesting stuff about that. I don't think we'll have time to talk about too much. Large bubbles can occlude blood flow. If you get arterial or venous gas embolisms, they will actually become big enough bubbles to prevent the blood from flowing around, same way a fat embolism or clot or other emboli works. And they can mechanically impair organ and tissue function. So you can actually pop a lung or pop an eardrum by coming up too fast and having gas come out of solution too fast, or having gas expand too fast, either way. So dive injuries occur when a diver ascends too quickly. We talked about this a couple of minutes ago. The gas that's dissolved in their tissue or blood forms bubbles before it can be transported to the lungs. The gas that's contained in their lungs, ears, or other gas-filled spaces expands very rapidly and causes damage to or ruptures the lungs, the tympanic membranes, or other organs. In terms of mechanical damage, the lungs are probably like the biggest, scariest eventuality. Eardrums suck, but they're fixable. But mechanical damage to the lungs can obviously be very problematic. So we're going to talk about DCI and DCS. I don't know if you guys are familiar with these terms or not. DCS and DCI are commonly used interchangeably, and that's not actually correct. The two are moderately different, have moderately different meanings. Decompression sickness, DCS, is the term for conditions in which dissolved gas has precipitated into a gaseous state inside tissue. So we're talking about when gas has come out of solution in your joints, in your blood, not necessarily, pardon me, inside your joints, inside your eardrum, inside your cerebrospinal fluid, things like that. Decompression illness is a broader category that includes both DCS and lung overexpansion and barotraumatic injuries. So DCS is a subset of DCI, but DCI also includes lung overexpansion, other barotraumatic injuries, things like that. We're going to talk about some categorizations of these things as well. So decompression sickness. And by the way, guys, nobody's going to fault you for getting these two things flip-flopped in your head. Everybody, including half the physicians I work with, flip-flop these all the time. It's just a technicality that'll make you look really good if you get it right. Decompression sickness. So DCS is broken into a few different categories. Generally speaking, we talk about type 1 and type 2 DCS. So type 1 DCS, or simple DCS, has cutaneous symptoms, so skin-related symptoms, joint and limb pain, which is commonly referred to as the bends, and I'm making air quotes when I say that, the bends. A a lot of people talk about dive injuries as in general as the bends. It's sort of how Kleenex is all facial tissue now. If someone says the bends, they might mean type 1 DCS, or they might mean all of this stuff put together. You kind of need to talk to them and clarify. Type 1 DCS also includes isolated vestibular symptoms, which we'll talk about a bit as we move forward. Type 2, or more serious DCS, includes neurological injuries, both peripheral and central. Central neurological injuries are actually more common than peripheral for a number of reasons. And major organ involvement, or major organ involvement. So direct hyperbaric trauma to major organs, or impaired circulation as a result of gas emboli or other obstructions. You might see sometimes type 3 DCS referred to. It's been referred to in a couple of pieces of literature, but it's a term that never really caught on. It's occasionally referenced. It's generally used interchangeably to mean arterial gas embolisms and lung overexpansion injuries. You should know that that's what it means. If you see it, you're unlikely to actually see people refer to type 3 DCS that much these days. So we're going to talk about where gas bubbles form. Gas bubbles can form in blood. They can form in tissue. They can form along nerves. They can form in lungs. Now, if a gas bubble forms inside a lung, it's probably not going to be too much of a problem depending on where it forms, because it should just be breathed out, generally speaking, unless it forms in the tissue of the lungs and it's somehow obstructed from transferring itself out. Gas bubbles can form in vestibular spaces. Vestibular bends are notoriously nasty to treat. They're really, really unpleasant for the patients. Bubbles can form in synovial fluid. That's the bends. And the reason that's called the bends, we'll talk about that. I got a slide on that later. Pardon me. And anywhere else that there is fluid that might have been gas saturated. So if you've been diving, you've been down at pressure for a reasonable period of time, you really could have gas bubbles forming anywhere. And that's why DCS and dive injuries in general are such a broad category, because it's actually a mechanism of injury, not so much a specific type of injury. And the mechanism of injury can be applied to many, many parts of the body and have many, many symptoms. We're going to talk about that as we go forward as well. So type 1 DCS. So type 1 DCS, decompression sickness, is sometimes called minor DCS, but it can still be serious and it should be assessed by a physician. Type 1 DCS is, again, that cutaneous involvement, skin bends, can involve the lymphatic system, can involve musculoskeletal structures, especially the bursa and synovial fluid, which is the bends. Type 1 DCS, and I know I'm reading my bullet points backwards here, sorry about that, guys. Type 1 DCS can be a sign of imminent presentation of type 2 DCS, especially if type 1 dive injury or decompression sickness presents very soon after a dive. Not a div, a dive. What I mean by that is if someone comes up from a dive and they manage to be running about on the surface for 45 minutes or 50 minutes or something, and then they have some type 1 DCS symptoms starting to present, that's a moderately rapid presentation. There's a reasonable chance that they're actually going to have a more significant and more major complication sequential to that. If they've been up and out of the water for 16 or 20 hours before they have any symptoms, it's likely that those are going to be their only symptoms. This isn't a sure thing. This is more of a just thing to keep your antennas tweaked about. So in musculoskeletal systems, type 1 DCS often manifests in large joints like elbows, shoulders, knees, hips. In cutaneous DCS, this often results in a rash and itching. We're going to see some pictures of cutaneous DCS. Back here I did mention cutis marmorata. That's the name of the specific rash that in the context of dive injuries is associated with type 1 DCS. Type 1 DCS also generally comes along with general fatigue and wiggles and niggles. And wiggles and niggles is a British term that quite a few of the guys that I dove with in Thailand would use. And you come up out of the water and you're just like, oh, I just can't quite get comfortable, you know? Stuff's not quite right. In and of themselves, is probably a good indication that you should stay out of the water. Or if they're getting worse and worse and worse and worse, they could be an indication of a dive injury worsening. cutis marmorata is a specific pattern of rash, and some of the other healthcare professionals we have in the group might be able to actually speak to other things that can cause cutis marmorata, but in the presence of or immediately following a dive, the presentation of cutis marmorata should be a pretty good indication that someone may have a dive injury that may be worsening. This particular picture is from the New England Journal of Medicine, and it was actually specifically from a dive injury. And this is not the best picture in the world. It's a little bit low resolution. I just found this on the internet, but it is ostensibly from a dive injury. I believe that it's from a dive injury. This is a much larger presentation of cutis marmorata, going from about the nipple line down. So lymphatic decompression sickness. So lymphatic decompression sickness occurs when bubbles obstruct lymphatic drainage from a region of the body. Specifically, you get a bubble that forms in one of your lymphatic ducts, and it'll prevent lymphatic fluid from draining. It can result in dramatic swelling and fluid retention in that area. Lymphatic DCS is potentially limb-threatening if the swelling impairs circulation. If in and of itself, it's not necessarily dangerous. It does look quite dramatic. It's not especially common. I've only ever seen it once. It was lucky enough to be in a friend of mine, and we actually had quite a bit of fun teasing her about it. But if you ever see that, you see one limb of a diver swelling up and you're not sure why, there's a reasonable chance they've got a lymphatic bend. The bends are by far the most widely recognized form of DCS. This is the term that, pardon me, that everyone recognizes as being synonymous with dive injuries. And these occur when bubbles form in the synovial fluid of joints. I think that's my next slide, yeah. So when you have bubbles form in the synovial fluid of joints, you're going to end up with stiffness and pain on both active and passive movement, and sometimes also crepitus. So if you guys can see here, I know everyone should be familiar with the general structure of synovial joints, but if you imagine what would happen if you had a whole bunch of bubbles form inside the synovial cavity or inside the synovial fluid, and then interfere with the articulation of those two bone ends or bone surfaces or cartilaginous surfaces, I guess technically. That's what's happening with the bends. And if you move your arm actively, it hurts, but if you just lay limp and let someone else move your arm as well, it's also going to hurt, also going to be quite stiff and uncomfortable. Many technical and deep divers, and we're going to talk about terminology later, many technical and deep divers are accustomed to minor and type 1 DCI, or DCS, pardon me, and might self-medicate. You're going to laugh at this. Many tech divers will argue with you till the cows come home that what they really need to fix themselves is a couple of beers and 24 hours of surface time. I would encourage you to protest their own attempts to self-medicate and try and get them to see a physician. You might not be able to. Whatever they say, there are actually urban legends about alcohol helping, like off gas and stuff. That's complete hogwash. Doesn't matter how much they try and sell you on it. It's not true. They probably should see a doctor if they've been deep diving and have problems. Vestibular DCS. So the vestibular system, again, is the inner ear. Vestibular DCS, you're getting bubbles inside your inner ear, can do a bunch of things. They can affect balance badly and cause nausea, vomiting because of all the balance problems, all the vertigo. Vestibular DCS can be strongly resistant to normobaric oxygen therapy. So that means that giving people oxygen at surface pressures is unlikely to fix their problem, right? Most of the other forms of DCS, and we'll talk a little bit about why in a few minutes, will respond somewhat positively to oxygen therapy at the surface. Vestibular bends generally don't. They are extremely unpleasant. I've never had one. I have seen other people have them. It's like the worst case of vertigo you've ever had in your whole life. Normally happens to you while you're out on a boat bouncing around in the ocean as well. So it really sucks. Type 2 DCS. So type 2 DCS is defined by central nervous system or major organ involvement. Type 2 DCS is the scary stuff, and I want to re-emphasize what I said earlier about anyone with dive injuries being presumed to be unstable, this is the reason why I'm saying that. Type 2 DCS has the potential to be immediately life-threatening. Type 2 DCS should scare the jeepers out of anyone who's actually going to be in an environment where they're going to be treating divers. So, type 2 DCS is the result of a couple of possible things: impaired blood flow secondary to an arterial gas embolism, or direct barotrauma from localized bubble nucleation. Barotrauma is a word that means trauma or damage from the pressure. So a bubble has formed and is actually pushing or impinging or tearing or whatever tissue in a local region. Or you have a region of the body that's receiving poor circulation because it's being impaired by a bubble in the artery. So I'm gonna put something out to the group here. This is something that I was taught when I was a wee dive medic in Thailand, and I was learning from these guys from Plymouth. And I was taught that myelin is the sheathing material that surrounds many nerve cells and serves in part as the electrical insulation of the nervous system. That's well established. And when nitrogen precipitates out of solution, so as pressure drops, nitrogen comes out of solution, and it likes to preferentially bind to or nucleate, create small bubbles around myelin. So I've treated this as gospel because this was actually what was taught to me like 10 years ago. Yeah, God, 10 years ago. When I was doing my training as a dive medic. But when I was prepping this lecture, I couldn't actually find a source to verify this. So if anybody feels like finding me a source, I would be thrilled. If not, maybe I'll have to revise what I'm teaching here. This was the prevailing wisdom for a long time, and this was what was being taught for a long time. Type 2 DCS patients may deteriorate rapidly. So type 2 DCS patients, if you've got bubbles forming in, say, your cerebrospinal fluid, and you have a bubble form, and it starts to get bigger and bigger and bigger and bigger and bigger, and then it starts to move around in fluid as bubbles do, you guys can probably understand why things might change or get worse very, very quickly. Same thing with bubbles in arteries. Bubbles can lodge and they get bigger and bigger, and then a big bubble breaks off and goes flying down an artery somewhere and lodges in a brain or a coronary artery or something else. Bad things happen. If you suspect your patient has type 2 DCS or is moving towards type 2 DCS, they should be regarded as profoundly unstable, even if their initial symptoms are mild. I really want to emphasize this, guys. Bilateral IVs, as much oxygen as you can possibly give them, run as fast as you can. Any central neurological symptoms post-dive should be regarded as sentinel events. What I mean by sentinel events is, the guy standing beside the road waving the red flag going like, hey, idiot, pay attention to this. Any presence of central neurological symptoms should be regarded as really, really worrying, because if something's affecting the brain, bubbles tend to get bigger, not smaller, right? I don't have time for an anecdote right now, but I've seen one of these go really, really badly from a really, really minimal initial presentation. Any disruption of ABCs, so airway, breathing, circulation, post-dive, even if it's transient, should be regarded as a sentinel event. This is less common, but if someone has this like weird shortness of breath that lasts for a couple of minutes or 10 minutes and then it goes away, you guys probably shouldn't just like, oh, well, that was unfortunate. Maybe it won't come back. That would be a really good indication that something's gone wrong. There's potentially a dive injury in place and the person should seek medical aid at a hyperbaric facility. We're going to do another cat break really fast. I like cats, by the way. This is one of my favorite cat memes. It makes me laugh every time. I really hope this is not what everyone who is listening is feeling right now. So lung overexpansion injuries. We are sort of getting towards the end here. I'm going to irritate Mandy and Ted by going over 45 minutes. Sorry, guys. I told you I would. Lung overexpansion injuries. So lung overexpansion injuries can result in a few different things. Let's start with what lung overexpansion injuries are. Lung overexpansion injuries are when you come up from depth. We already talked about gas expanding. If a diver is not breathing out or exhaling as they ascend from depth, they can actually cause a mechanical injury to their lung itself and basically pop a lung. It's not quite as dramatic as a balloon popping, but you can actually rupture the tissue of the lung if you're not exhaling enough gas fast enough as you ascend. That can result in a few different things. That can result in an air embolism in an artery. That can result in a pneumothorax, which would be very likely to progress to a tension pneumo in this case. Could result in mediastinal emphysema. Could result in subcutaneous emphysema. We're going to talk about these 4 things here. So arterial gas embolisms, as we talked about, are very bad things. They impair circulation. They cause, in the brain, they cause strokes. In the heart, they cause MIs. In the bowel, they cause ischemic gut. Other organ failure and tissue death, they're generally bad things. When you cut off circulation to parts of your body, nothing good generally comes of it. Mediastinal and subcu emphysema are both fairly common complications of lung overexpansion injuries. Mediastinal emphysema can be life-threatening, or is life-threatening. It'll often result in compression of the heart and the great vessels. So that's, again, increased pressure in the cavity immediately around your heart. Subcutaneous emphysema, if anyone has ever seen this before, is when gas, air or whatever other gas is present, gets into the tissue underneath the cutaneous surface or underneath your skin. Feels like bubble wrap or kind of like a snap, crackle, pop, Kellogg's Rice Krispies. Same sort of idea. Subcu emphysema is not life-threatening in and of itself, but nothing good causes subcutaneous emphysema. If it's there, it's an indication that there's been some sort of breach of the lung. There's somehow been gas introduced into a space underneath the skin. You should go looking for the other stuff that's wrong, and you should be really worried that there are, in fact, other life-threatening injuries that you haven't found yet, even if they're not obvious to you at the time. Neurological injuries are very, very common in dive injuries. So when bubbles form in cerebrospinal fluid, they can directly impinge on the spinal cord and cause localized peripheral deficits. So in the same way that a physical or traumatic injury to a particular part of the spine can actually cause limb dysfunction or limb paresthesia, bubbles forming inside the cerebrospinal fluid can crush the spinal cord or squeeze the spinal cord and cause peripheral paresthesias. If you have a dermatome chart, if you're familiar with these, you can actually localize where the bubbles are in the spinal cord and watch them migrate. And if it wasn't for the fact that it's like a really, really major medical emergency, it's actually pretty cool and interesting stuff. We're not going to focus too much on dermatomes tonight. Symptom summaries. So in a patient with a history of diving or ascending to altitude, and we didn't get too much into ascending to altitude, but you can get the same thing. If you go from sea level to 50,000 feet really, really fast, you can also have gas come out of solution as the pressure decreases around you. In a patient with a history of diving or ascending to altitude in the past 48 hours, the following signs and symptoms may indicate the presence of a hyperbaric injury. And again, guys, this is a really long list, and I'm trying to make a point. I'm not trying to be an idiot and just be like, oh, look at all these symptoms. I'm trying to make a point about how broad of a phenomenon this can be, okay? So type 1 DCS generally has gradual onset, joint pain, unexplained fatigue, dizziness, local or regional edema, niggles, cutis marmorata, that mottled skin we talked about, which can be a good indication of a progression to type 2 DCS. Type 2 DCS, again, a gradual onset, can be a sudden onset depending on whether there's an arterial gas embolism present or not. Central or peripheral nervous system involvement can range from numbness and tingling through to paralysis, seizures, death. Can be transient and migratory. And then this is the full list, again in air quotes, because I'm sure there's more stuff that I haven't thought of here, of things that can go wrong post-dive that should indicate or should suggest to you that dive injury might have happened. Specifically, I want you guys to pay attention to all of the central neurological stuff. So the memory loss, the confusion, visual abnormalities, visual field disturbances, blindness, unexplained mood or behavior changes, things that are really easily written off to, oh, they're just having a crappy day, their dive didn't go that well, they're grumpy, whatever. Unexplained fatigue, unconsciousness, a whole bunch of other stuff here, again, like urinary incontinence, bowel incontinence. This stuff could be mechanical, this stuff could be neurological, poorly localized aches, vertigo, nausea, vomiting. I'll let you guys read through this list once it's posted up on YouTube in a week or two. So, management of DCI, really fast. What are we going to do about this? We've already told you. It's really, really simple. Treatment and management is really, really straightforward. Give them as much oxygen as possible. For those of you who have done an AIM course and know about no DSAT, using nasal prongs as well as a non-rebreather, that's not a bad idea. Increasing the amount of oxygen available to a person, or increasing the purity of oxygen in their lungs, is going to increase the speed at which the nitrogen can be pushed from their bloodstream into their lungs and then breathed out. The more oxygen, the better, right? I know there's all this other stuff about like over-oxygenating people and stuff. In this context, the more oxygen, the better. In fact, and this is what we're going to learn next week when we go to the chamber, we want them to have so much oxygen that we can't actually give them enough pure oxygen at sea level. So we're going to go and give them pure oxygen under pressure. And if you guys remember that beautiful Photoshop artwork that I did earlier and all that extra nitrogen floating around, we're going to go and replace all of that extra nitrogen with extra oxygen because we want them to have so much more oxygen than we can give them at sea level. Okay. Manage your immediate symptoms. So if they have an airway problem, manage the airway problem. If they have a breathing problem, manage the breathing problem. Try and limit movement. This is especially important if you think you have transitory or migratory bubble issues. Bubbles like to move and bounce and stuff, and the less you move your patient, the less likely it is that things are going to get dislodged and things will change. Do transport your patient as rapidly as possible to a recompression facility. I didn't put this in the bullet points, but I do feel like I should mention it. Under absolutely no circumstances should anyone ever try what's called an in-water recompression, which means do not, under any circumstances, stick your diver back in the water, try to send them back down to depth to recompress them, and then bring them up slowly. I'm not going to go into the hows and whys tonight. Just don't do it. People have tried it. It's a really good way to kill your patient for a number of reasons. Just don't. Get them to a proper medical facility that can handle what's wrong with them. Provide as much oxygen as possible. This was a question that came up a little while ago. If you have limited oxygen supplies, what's the best thing to do? These injuries often happen in remote locations, hours or days away from medical facilities. It is theoretically better to provide a moderate oxygen supply for a long period of time than high flow oxygen for a short period of time. I'm not aware of any studies that have actually tried to track that, but certainly the theory would suggest that providing them with high oxygen for a long time is better than very, very high oxygen for a short time. The more oxygen the patient receives, the higher the partial pressure gradient that's pulling the nitrogen or helium out of solution into lungs. That should be HE2, by the way, sorry. Again, I'm not going to go into partial pressures right now and ideal gas laws and stuff, but more oxygen, good. Deal with what's immediately in front of you. If they're in pain, don't give them Entonox. Please, because Entonox contains what? A whole bunch of nitrogen, which is exactly what you're trying to get out of their body. They're just going to have to suck it up and deal with the pain. Support the ABCs as best you're able to. Limit exertion and movement, right? So that reduces bubble migration travel. Also reduces the physiological needs of the patient. Do transport rapidly because these people really need a hyperbaric facility. Give them as much oxygen as you can. Go real fast. If you're able to, and those of you who are divers will hopefully be a little bit better equipped to do this than others, record any available information about the diver's dive history over the past 48 hours, especially their most recent dive, but really what they've been doing for the last 48 or even 72 hours. If they have a dive buddy that they've been diving with, some people dive without dive buddies. Most people should have a dive buddy. Their dive buddy may be very helpful in this regard. If you can't bring their dive buddy with you, get their phone number, because I guarantee you the doc at the hyperbaric facility is going to want to know what their dive history and profile was. And if they can't answer it themselves, someone's got to. Do bring their dive computer and cables with you. Dive computers are often worn on the wrist. Sometimes they're attached to other parts of their buoyancy compensation devices or gauges. Bring the dive computer, and if you can, bring the cables, because there's a good chance that the folks at VGH can actually download the hyperbaric information off the dive computer and find out what this diver has actually been doing. That can be really useful in injuries where a diver lost contact with their group for a period of time and nobody really knows how deep they went or for how long. Their computer is probably strapped to them and has a record of that. So, finishing off things, guys, the end of the lecture again. Until you know otherwise, patients with a suspected dive injury caused by rapid ascent or missed decompression stop should be regarded as profoundly unstable. I hope you guys understand why now. Even if they look fine, symptoms can present in a delayed fashion, minutes or hours after an injury or after a dive. Pardon me. It is possible for dive injuries to present up to 48 hours after a dive. Statistically speaking, something like 90% are within the first 24 hours, and like 60% are within the first 4 hours. I'm not sure on those numbers there, but it's in that neighborhood. The more oxygen you can give them, the better. If you have an ambulance loaded with oxygen, use all of it. Go for it. Do be ready for neurological, respiratory, and pain-related complications. Never, ever, ever give them Entonox, no matter what. Do record information about their dive depth and time if you can. Call for someone who knows lots to provide more technical advice to you. And I should have said this earlier, but do phone ahead to the hospital. I guarantee you, Vancouver General is going to be really, really miffed if you show up with a dive injury at their doorstep and you haven't told them about it in advance. If you want to know more about how blood gases work, what partial pressures are, post your questions to the HCP Facebook group, and I will do my best to answer them. Mandy has kindly pointed out that many of you might not have access to the HCP Facebook group if you're not actually practicing professionals. If that is the case, please post them to the Facebook comment or YouTube comments underneath this video once it gets posted online, and I will do my best to answer them there. Okay, and I will try and cross-post stuff that gets posted to Facebook. I'll try and post to YouTube and vice versa, so there's a proper repository. That's it, guys. There's a bit of terminology here that I'm just going to scroll through very slowly as we sort of finish things off here. This is more just for people's reference than anything else. But Mandy and Ted, back to you guys. Are there any questions?
Thank you very much, Nick. That was really interesting. A tour de force to a really complex topic. We definitely have a couple minutes left. If people have any questions, they can fire them away in the questions tab, and we can address them now, or also once the video gets posted up to YouTube, the comment section on the YouTube video is also a good place. We can have these sort of conversations.
Oh, that's my question.
Mandy, we can start out. Mandy herself has a question.
So thanks, Nick. It was really interesting. I just vaguely remember in my practice that when we suspect an air embolism, we used to put them on the side, reverse Trendelenburg with the legs up, kind of to promote the migration of the bubble towards the leg versus the brain. Comment on that?
My understanding, and I would want to go and actually cite a source on this to be really firm on it. My understanding was that was an old practice that sort of was demonstrated to not be of very much use. Actually about 10 years ago, but because it was such a prevalent area, and the theory is kind of sound, but my understanding is that it was sort of demonstrated to not really have much clinical effect. So, you're probably not going to do any harm, but it's probably going to make it harder to manage your patient with their feet up in the air. So,
Well, thanks. I guess it just confirms that I'm older than I look. But thanks.
We've got a question from Sally. Sally's got a great one here. How about the risks of flying after diving? It's an interesting one. I know anecdotally there was one case that the BCR ambulance transported the helicopter where they actually flew under the Lionsgate Bridge to take them into Vancouver General Hospital.
I have heard of that specific case, Ted. So one of the things you'll learn when you go diving and go do your actual open water course, one of the things that they will hammer into you is that you cannot fly. I believe Patty, the last time I heard, was saying for 24 hours after a dive, you should not fly. Absolutely. I would personally, having seen people have injuries outside of that window, I would extend that to a minimum of 48 hours. And I personally won't fly within about half a week of having been underwater. Having said that, you are entirely right, Sally. Decreasing the pressure that you're in after you've been diving will absolutely promote or increase the likelihood of dive injuries. And you will find that patients who are air evac'd, I believe, now, don't tell the pilots I said this, Ted. I believe the medical standard for taking a patient to altitude after a dive injury is like keep them below 1,500 feet or 1,000 feet, which means they probably would have been fine to go over the Lionsgate Bridge. But you know, if you've got an excuse to go under it, that doesn't sound like a bad idea. So you know, good for them for taking the initiative and going the extra mile for patient care. I've certainly always heard 1,500 feet as sort of the max cap, but again, I'd want to look up an actual reference before I stuck my neck out on that one.
I think Mandy had a follow-up.
Yeah, I think I've actually asked a similar question to one of our hyperbaric chamber docs, and verdict is that between getting a person to a hyperbaric chamber and the no fly for the risk, they'd rather get the person to the chamber and deal with all the consequences, potential consequences, than to not transport someone to a hyperbaric chamber or take longer because they're scared of flying.
Yes, absolutely. I was obviously a bit tight on time, so I didn't go too much into this, but the only definitive treatment for a dive injury is hyperbaric recompression in a chamber. You can mitigate the damage being caused with normobaric oxygen. And I mean, in theory, for minor DCI, you could, over a longer or a much longer period of time, mitigate the damage or reverse the injury or reverse the bubble formation through administration of pure oxygen at normal sea level pressures. But absolutely. For context, for those of you who are BC Ambulance, dive injuries actually trigger an auto launch regardless of the presentation of the patient on the crew's arrival. So if you're more than whatever it is, 20 or 30 minutes away from a hospital, and you phone 911 and say, buddy just popped up to the surface, he's got a dive injury, he's got really sore joints, and he's screaming in pain, that'll actually trigger a helicopter launch right away, which should give you an idea of how seriously these things are treated and taken, and how badly things can go wrong if you don't get someone into care quickly.
Excellent. Well, I think we'll wrap it up there. Thank you again, Nick, for a really great presentation, and thanks for the questions. Just a reminder, we do have the hyperbaric tour that's still available. There's a couple of seats there. They'll talk about some of the things we've talked about tonight, as well as some of the other uses for the chamber as well, beyond diving injuries, toxic exposures, that sort of thing will be covered. So at this point, we'll bid everyone a good evening, and we will see you next month for the presentation. Thank you very much.